Lacey, the floor is yours.
Okay, very good. Well, welcome for the NorCal Carcinet meeting with UCSF, the bi-monthly UCSF partnership with NorCal Carcinet. I was happy to have Dr. Mandar Aras today with us. Dr. Aras is an assistant professor at UCSF, and his clinical interests are in the evaluation and management of patients with advanced heart failure and pulmonary hypertension, including patients requiring heart transplant and left ventricular assist devices. He has a particular interest in prevention and treatment of patients with heart disease related to chemotherapy. His research interests are in understanding genetic and molecular mechanisms of heart failure and developing novel biomarkers in patients with advanced heart disease. Dr. Aras comes to us with training, University of Pittsburgh for his medical degree, residency at Duke University, and fellowships both in cardiovascular disease and advanced heart failure and transplant at UCSF. We are thrilled to have him here with us today. Dr. Aras.
Thank you so much, Lacey. It's a pleasure and honor to be here, and thank you so much for that warm introduction. I'm going to share my slides here. Okay, can everyone see that?
So yes, we can.
Okay, perfect. Great. So again, my name is Mandar Aras. I'm one of the heart failure cardiologists here at UCSF. And over the past 3 years or so, I've sort of taken over the Carcinoid program in terms of the Carcinoid heart program, and see a lot of patients with carcinoid heart disease. And so I've prepared a couple of slides here, about 25 slides or so, to give an overview of carcinoid heart disease, leaving plenty of time towards the end for questions and discussion. I have no relevant disclosures that are relevant to the topics presented here. And just a brief outline of what we're going to talk about today. I'd like to first go over epidemiology and some definitions. I'd then like to talk about pathophysiology and clinical manifestations of carcinoid heart disease, and then talk a little bit more about diagnosis and monitoring, followed by treatment of carcinoid heart disease and perioperative management. So let's begin with some definitions. So neuroendocrine tumors, or any NETs, are rare neoplasms. The incidence is about 2.5 to 5 cases per 100,000. They can occur anywhere in the body, but most often originate in the GI tract. GI NETs were originally termed carcinoids because they produce these substances that lead to carcinoid syndrome. And carcinoid tumors are usually very slow growing and take over years to grow. And symptoms begin when these tumors are large or metastatic. The carcinoid syndrome occurs in about 30 to 40% of patients with NETs. And these are described as episodic vasomotor changes, specifically flushing, low blood pressure called hypotension, diarrhea, or bronchospasm, which is like a wheezing type sensation. It occurs in most patients when the tumors metastasize or spread to the liver. In some patients, about 5% in some reports, may present with carcinoid syndrome without liver metastases. Now, carcinoid heart disease is the specific development of plaque-like fibrinous thickening of the heart valves or the lining of the heart. And it leads to progressive dysfunction of the valves that are involved, mostly the right-sided valves, and we'll talk a little bit more about that later. It is associated with higher morbidity and mortality, meaning that it can lead to complications from due to the presence of heart disease and limits the lifespan. And it's reported to be present in about 20 to 50% of patients with carcinoid syndrome. But because of recent therapies and novel medications, there has been a decline in prevalence. Now, taking a step back a little bit, I'm a heart failure cardiologist. How do we assess severity of heart failure? So this is a nice slide talking about some of the lingo that we use. And I want you to pay particular attention to the functional class, which is on the right. That's the New York Heart Association functional class. And this is a classification of how patients, what symptoms they experience with their heart disease. Asymptomatic, or class 1, that means that you don't really have any symptoms that limit your exercise tolerance or your ability to exert yourself. Class 2 means that you have symptoms with moderate exertion, something like going up hills or going upstairs. Class 3 patients are those that have symptoms with minimal activity, something like doing chores around the house or gardening or walking on flat ground. And finally, class 4 means that you have symptoms at rest. And this is how we classify patients with heart failure, and it'll be relevant to our discussion later on. And patients can move between or among classes depending on medications and things like that. So class 4 patients aren't necessarily class 4 patients forever. With medications or with other interventions, they can move and improve to class 2 or even class 1. So to summarize this first part of the talk, again, some definitions and epidemiology. In the general population, about 2.5 to 5 cases per 100,000 have NET. Among the NET patients, about 30 to 40% have carcinoid syndrome, which is the syndrome of the flushing, diarrhea, and low blood pressure. And then among those patients, about 20 to 50% have carcinoid heart disease, which is the specific involvement of the heart. Let's next talk a little bit more about the pathophysiology. So that basically means what causes carcinoid heart disease. Well, it's a little complicated and not quite understood. There are these vasoactive substances that are secreted by the tumor that play a role. 5-HT is one of the most prominent ones, but other ones have also been described, like prostaglandins, histamine, bradykinin. And the reason why 5-HT is been shown to be the most important is because there's receptors for 5-HT within the heart. Specifically, the 5-HT2B subtype is very prevalent on cardiac valves. And 5-HT acting on this receptor leads to the activation of inflammation and fibrosis pathways. So basically causing fibrosis of that area that's involved. And this fibrosis and inflammation leads to plaque-like deposition on the valves and some of the lining of the cardiac chambers. This is a visual description of what I just said. So here, these carcinoid plaques are shown in this sand color, and you can see the deposition of these plaques on the tricuspid valve, which is one of the right-sided valves here, along the right-sided atrium, along the right-sided ventricle, and what's not shown here is the pulmonic valve, which is on the outflow tract of the right side. Occasionally, we can also see some involvement of these plaques on left-sided heart structures. So here's another schematic. Again, substances like 5-HT are secreted by the tumor, and the amount of 5-HT that isn't broken down by the liver then gets through the bloodstream into the vena cava and into the heart. Alternatively, if you have hepatic metastases, they can also produce the 5-HT directly into the bloodstream, which then travels to the heart and again affects the right-sided heart structures predominantly. The tricuspid valve shown here, as well as the pulmonic valve here. Again, 1/3 of cases can also affect left-sided structures, And these are in patients that have a patent foramen ovale, which means that they have a small connection between the right and left side. Patients with bronchial carcinoid also are at risk of developing carcinoid heart disease on the left side. And then patients that have very high circulating levels of the vasoactive substances can also develop left-sided carcinoid involvement. So what's the prognosis of carcinoid heart disease? Well, without treatment, the 3-year survival is reported to be as low as 31%, versus 68% in patients that don't have carcinoid heart disease. But again, prognosis is improving, largely due to a lot of the new anti-tumor therapies, the increased awareness of this, the routine screening with cardiac imaging, perioperative management, and early referrals for valve replacement surgery. What are the clinical features of carcinoid heart disease? Well, the bottom line is they're not very specific and can only manifest and can sometimes manifest in very advanced stage disease. Some of these symptoms are dyspnea or shortness of breath, fatigue, a systolic murmur that is best heard on the sternal border and increases with inspiration, jugular venous pressure, which means elevation of the neck veins, and then evidence of fluid overload, and that can be swelling in your legs, swelling of the belly, or fluid accumulation in the lungs. Again, a lot of these features or symptoms are not specific to carcinoid heart disease. We see it in a lot of other types of heart disease as well. Symptoms typically occur between the 5th and 7th decades of life, with a mean age around 55 to 60 years in epidemiology studies. And there's been reported to be a diagnostic lag, so patients may develop onset of symptoms but don't get diagnosed with carcinoid heart disease for 24 to 28 months. Mostly, I think, because these symptoms are nonspecific, like fatigue. And majority of patients that do present with carcinoid heart disease present with right-sided symptoms for the reasons that we mentioned before. And like I said, swelling, the fluid accumulation can be due to other reasons, not just heart disease, like liver disease, poor nutrition, or obstruction of the veins, of the central veins by a tumor. So how do we diagnose carcinoid heart disease? Well, echocardiogram, which is an ultrasound of the heart, is the best imaging modality of choice and is the gold standard. However, it's sometimes not feasible to get echocardiogram in a timely manner. It's hard to do repeated studies over and over again. And so biomarkers, which are blood and urine tests, have been shown to be useful. And among these, the NT-proBNP, which is a cardiac biomarker, has been shown to be the best one. It's validated for both diagnostic and prognostic value. The NT-proBNP is a biomarker that we commonly use in heart failure and indicates when the heart is stressed or strained. So enlargement of the heart can usually leads to higher plasma levels of this biomarker. In studies in carcinoid syndrome patients, a cutoff was found on the NT-proBNP of 260 with a 92% sensitivity and 91% specificity for development of carcinoid heart disease. What that means is among patients that have carcinoid syndrome, patients that had a NT-proBNP above 260 were at higher risk of having carcinoid heart disease. Other biomarkers like urinary and plasma 5-HIAA levels can also be used. In some studies, 24-hour urine levels of 5-HIAA above 300 conferred an increased risk of carcinoid heart disease. However, there's a lot of caveats with the 5-HIAA levels. Tryptophan can cause false positives, so dietary things can cause the levels to go up. And then certain medications can cause the measurement to go up or down. So it's a very tricky biomarker to use. I think NT-proBNP is a little bit easier to use. Other biomarkers that have been evaluated in the past, like chromogranin A or activin A, have been shown to be not that useful. Okay, so let's talk about imaging. So like I said before, echocardiogram is the gold standard, but there have been other imaging modalities like MRI, CT scan, and PET that have been developed that can help with the diagnosis and are complementary to the echocardiogram, or can be used when the echocardiogram is difficult because of poor windows. So this is just a schematic showing that CMR, which is MRI, CT scan, and PET can be used as in a complementary role to the echocardiogram. These are some of the characteristic or classic features on echo. So just for orientation, this is actually a transesophageal echo. This is the right atrium, this is the tricuspid valve, and this is the right ventricle. And as you can see here, this is from a patient with carcinoid heart disease. You can see that the tricuspid valve, despite it being open, has valve leaflets that are persistently open and stiff and don't open completely, and that results in regurgitation or leaking of blood flow from the ventricle to the atrium, which is in reverse of what it should happen. This is another echo view. Here, the right atrium is here, the tricuspid valve is here, and here's the right ventricle. Normally, blood should travel from the right atrium to through the tricuspid valve into the right ventricle. But again, this shows using Doppler that blood is flowing in the opposite direction because the valve is stiff and therefore doesn't close completely. So this is an algorithm from a recent paper suggesting that in patients that have carcinoid syndrome or serotonin-producing NETs, that these patients should get 6 months clinical assessment, so a 6-month doctor's visit, with measurement of the NT-proBNP. Now, if that NT-proBNP is less than 260, then I think you continue with clinical follow-up every 6 months. Now, if that NT-proBNP is elevated, remember that was the cutoff for higher risk of carcinoid heart disease, well then that should prompt your team to get an echocardiogram to look for some of these features of carcinoid heart disease. Now, if the echocardiogram does show carcinoid heart disease, then you should be referred to a cardiologist like me with expertise in dealing with patients with carcinoid heart disease. If there's no heart disease, but there's some other finding on echocardiogram, then you should be referred to a cardiologist. And if it's normal, then I think you can follow up with the biomarkers like NT-proBNP. Again, this is just a general guideline. We always say patients don't follow the book, and so this is just a guideline, but it can be used and adapted to specific patients. So now that we've identified carcinoid heart disease, what can we do about it? Well, I think it's a little complicated because you have to simultaneously address the cancer or the tumor as well as the cardiac involvement. You know, I commonly say in clinic that, you know, the heart is an innocent bystander. And so, yes, we have to deal with the heart disease, but we have to also deal with the tumor itself. And sometimes dealing with both simultaneously can be tricky. And so because of that, we recommend a multidisciplinary approach with the involvement of a NET oncologist, cardiologist, surgeon, anesthesiologist, and radiologist, like we have available at UCSF and at a number of other centers throughout the world. Now, the medical therapy for right-sided heart failure is complicated because there's not that many proven therapies. Unlike left-sided heart failure, which has a number of oral medications that can help patients feel better, stay out of the hospital, and live longer with left-sided heart failure. Right-sided heart failure is a lot trickier, where there aren't that many proven therapies. And so the focus has been on relieving symptoms of right-sided heart failure, mostly with diuretics. Diuretics, can affect the electrolytes and kidney function, so we need to monitor that with blood tests. And in some patients, can cause a reduction in cardiac output. So when the blood volume is reduced with diuretics, it can cause a reduction in cardiac output, and that can cause low blood pressure or feeling of shortness of breath. And at the same time, control of carcinoid syndrome symptoms is also a mainstay of therapy, and that's commonly done with somatostatin analogs. So again, treatment focuses on treating the syndrome symptoms as well as treating the heart disease. Now, cardiac surgery, namely valve replacement, is the most effective treatment option for advanced carcinoid disease. So this was a study that was published in 2011 where they took 40 patients with severe valve disease and 55% were referred for surgery. And the surgeries that were done were 3 tricuspid valve replacements, 15 tricuspid valve replacements with pulmonic valve replacements. 2 patients actually had 3 valves replaced, and 2 patients had 4 valves replaced. The 30-day mortality in all of these patients was about 18%, so 4 patients passed away within 30 days. And they looked at how people did. They looked at 3-month follow-up. And this is the New York Heart Association class that we talked about earlier on. So again, class 1 is no symptoms, class 4 is symptoms at rest. And the higher the number means the worse symptoms. And prior to surgery, you can see that 16 patients were class 2 or 3. And 3 months after surgery, the majority were class 1 and 2. So that suggests that patients felt better after surgery. Well, how did surgery affect survival? These are Kaplan-Meier curves that show survival over time. And the one on the left is stratified according to Heart Association class. So the dashed line are patients that had lower symptoms, and the dark line are patients that had higher symptoms at the time of surgery, and survival is shown here. And as you can see, while there's a trend towards patients that had lower symptoms doing better after surgery, the actual statistics did not reflect that. So there was no difference according to New York Heart Association class. And then the figure on the right shows a similar type figure, except it's stratified according to the dysfunction of the right ventricle. And you can see that these lines kind of overlap a little bit more so than the left figure, again, showing that there's no difference in survival according to the RV size. So then you might ask, well, then how do you know when is the best time for heart surgery? Well, I think that's still a question that's relatively open in the literature. The optimal timing of valve surgery is not clear. What we do know is that we follow general guidelines and general indications for surgery, and that includes patients that are fatigued and have symptoms of breathlessness leading to abdominal swelling or swelling in the legs that have carcinoid heart disease should be referred for surgery. That's number 1. Patients that don't have symptoms but do have findings on echocardiogram or imaging showing that the right ventricle is getting bigger with carcinoid heart disease, they should be referred for surgery. And then finally, there's a thought that patients that have carcinoid heart disease that are about to get liver surgery for their tumor should probably get their valves fixed prior to liver surgery. Finally, heart surgery should only be considered in patients that have an anticipated 1 year or more survival from their malignancy. So patients that don't have that survival, that are very sick, may not be best candidates for surgery. What about catheter-based or non-surgical interventional options? Well, catheter-based, minimally invasive interventions are novel. They're very exciting, and they may be considered for high-risk patients in whom surgery is not an option. But these are off-label and investigational approaches, so not a lot of centers do it, and if they do, they're not done routinely, so at a case-by-case basis. But it may be a more common practice in the future. You know, the field of structural interventions through a catheter has blossomed over the past 5 years and will continue to be an area of active development. So in summary, how do we treat carcinoid heart disease? Well, number one, we have to establish that there is carcinoid heart disease based on echocardiogram. If the echocardiogram is not clear, then we can get a transesophageal echocardiogram or a cardiac MRI. Number two, then we should try to control the progression of carcinoid syndrome with somatostatin analogs or other medications that are recommended by the oncologist. And then we determine whether there's mild disease or moderate to severe disease. Now, if there's mild disease, then I think it's reasonable to continue to follow the patient every 3 to 6 months with echocardiogram and biomarkers to look for progression. And sometimes we may use diuretics in this cohort of patients to help with symptoms and control the fluid levels. Now, in patients that have moderate or severe carcinoid heart disease, then clinical assessment and echocardiogram is probably necessary a little bit more frequently than 6 months. So this algorithm suggests every 3 months. And again, you know, frequent follow-up, determining whether there's development and progression of symptoms, and then early referral for surgical intervention is prudent. Perioperative management. So last, I want to talk about perioperative management. As you may know, patients with carcinoid syndrome are at risk of developing carcinoid crisis when receiving anesthesia, which can be life-threatening. Carcinoid crisis is mediated by a release of these biologically active substances, which cause blood pressure swings, particularly low blood pressure, fast heart rates or tachycardia, flushing, arrhythmias, and bronchospasm or wheezing. And so it's commonly recommended that if you're undergoing surgery, that you get admitted to the hospital 2 days prior to surgery. You get started on an octreotide infusion at a starting dose and maybe need the dose increased if necessary. And having the surgery done at an experienced center where the providers are experienced at taking care of patients with carcinoid syndrome. So the overall summary of my slides. So number one, carcinoid heart disease is associated with increased morbidity and mortality. Carcinoid heart disease needs to be assessed by a combination of clinical assessment, biomarkers, and echocardiogram. And surgical valve replacement can help symptoms and lifespan. Again, carcinoid heart disease probably best taken care of by a multidisciplinary team at an experienced center. Thank you so much for your attention, and I'm very happy to answer any questions and discuss some of the topics that I presented today.
So Dr. Aras, there are a few questions in the chat if you want to take a look real quick and respond to them. One is, can a leaky aortic valve be a symptom?
Yes. So I think if a leaky aortic valve is due to carcinoid, I think the first question there is whether the leaky aortic valve is due to carcinoid heart disease or whether there's a separate reason for that. So, I think that has to be assessed by an echocardiogram and imaging, maybe an MRI, and then we should, if it is due to carcinoid heart disease, then determine whether you're at risk for developing a left-sided symptom like that. So I mentioned 3 of the most common causes of left-sided carcinoid heart disease. Number 1, there being a patent foramen ovale. Number 2, there's a carcinoid in the lungs. And number 3, there's very high levels of 5-HT circulating. So can the leaky aortic valve be a symptom? Yes, it can, but a comprehensive evaluation needs to be done.
Secondly, there was another question about imaging or scans, and in regards to, perhaps here it's more conversation with an echo, but how often should this be done for patients?
I think it's variable depending on what's seen on the initial echo. So I think the indications for an echocardiogram are probably concern of carcinoid heart disease. So either through clinical assessment or the NT-proBNP, if there's concern for carcinoid heart disease, then I think obtaining an echo as a diagnostic modality is the first step. And then if there is evidence of carcinoid heart disease on that initial echo, then determining with a cardiologist and your team as to how frequently we should monitor with serial echoes is the next step. For mild symptoms, then perhaps every 6 to 12 months. For moderate to severe involvement, maybe 3 to 6 months.
So going back, talking about a baseline echo, is that something that should be done for all patients or that should be recommended for all patients, not only those with maybe mid-gut, but all versions of neuroendocrine tumor just as a baseline to have that for you, or is this something that's specific to people who have tumors who are 5-HIA producing?
Yes, I would say the latter. I would say the patients that have functional tumors, meaning that they produce 5-HIAA, I think, number 1, those patients should get an echocardiogram if there's a concern for carcinoid heart disease by, symptoms, or 2, they have an NT-proBNP that's above that cutoff of 260. So I think all patients with tumors, net tumors, should get that biomarker, that NT-proBNP. And then depending on that, you can determine whether or not you need an echocardiogram.
Other things that can happen to NETs and cardiology, I know that a lot of us are having genetic testing now, and some things are, and I know some of your work is in this area of understanding genetic mutations and other cardiac issues that are coming off. By the way, you can stop sharing your screen so we can see more of you, and UCSF Mount Zion or Parnas is a wonderful place, but I don't want to be there.
Sounds good.
Are there other things that, with all this new genetic testing that's going on that your research is looking at and that we should start being interested in or at least learning about?
To be determined, I would say. I think, I am doing a research project on determining whether there's genetic reasons for why some patients with cancer get heart disease. We don't have the data yet, but it is an area of investigation. So why do some patients develop carcinoid heart disease, despite having maybe equal levels of 5-HIAA circulating. We don't know, maybe there's a genetic component to it. To be determined.
Okay, there's one more in the chat window on someone had a gallium-68 pickup at the left ventricle. Is that carcinoid heart disease, or is it physiological uptake of gallium-68 dotatate?
Yeah, so that's a good question. I would talk to your oncologist about whether they think that there could be metastatic disease. The dotatate imaging, as far as I know, because it's targeted towards the somatostatin receptors, it shouldn't light up in the heart. And so if there is if the dotatate does pick up something in the heart, then it's probably metastatic disease. That's my understanding.
Like
again,
they
I'm not an
certainly had
oncologist.
some procedure done 15 years ago. So I don't know if there's any physiological uptake that could come from that as well, because there are other things that do show up a little bit. There's another question about surgery when someone's liver is too diseased. What options are there if surgery is contraindicated?
Yeah, so surgery is not for everybody, and I think because of liver disease or uncontrolled carcinoid syndrome symptoms, surgery may not be safe. And so in that case, I think a conversation about maybe the catheter-based approach could be had with your cardiologist, and seeing whether that's available. Again, these are off-label, investigational, research-based type procedures at this point for carcinoid heart disease, but there are some centers that are more comfortable at doing this than others.